Vitamin D3, we talked about rickets. And what was the deficiency of vitamin D in adults? Osteomalacia? Yes. Epidermal growth factor. From the name, epidermal growth factor. It's a factor that promotes the growth of the epidermis. And the epidermis, obviously, is the outer layer of the two layers. And the second one is, the deeper one is? Dermis. It's produced by salivary gland or the duodenum. And they use that actually in the laboratory. You know, if somebody's getting a burn or something in the face, they remove this part and they get a patch, usually from the medial aspect of the thigh or something, the closest to the face, and they patch it or graft it or stuff like this. It's not going to be perfect. So what they're doing right now is they take part of the skin, just a little part, in the laboratory, and they add this factor to grow and make like a patch the way they want it to look like. Okay, they are working on that to improve the skin graft. So basically, it is promoting everything in the skin. Germinative cells. What are the germinative cells? Stem cells. And which layer is it? The deepest or the most superficial or in the middle? Germinative? It's the deepest. It's the deepest one. Acceleration of keratin production, repair, secretion. So it's basically stimulating everything in the skin. The next layer is the derms. And the dermis is what contain all the accessories. It doesn't mean you will not see it in the epidermis. You will. But where does it originate? It originates from the dermis. Hair, follicles, sweat glands, any sebaceous glands, any other glands. And it consists of two layers, papillary layer and reticular layer. Papillary layer. Why did you call it papillary layer? Because they contain papillae. What are the papillae? This is what locks in, fits in with the epidermal ridges. And the epidermal ridges is what makes what? What's the significance? Fingerprints. Fingerprints. And this, the papillary layer is contain, both of them actually will contain blood vessels, lymphatics, and nerves. But what's the difference? The papillary will contain the smaller of those. Small capillaries, lymphatics, sensory neurons, while the reticular layer contain same thing but larger. Larger blood vessels, larger lymph vessels, larger nerve fibers. So both of them contain blood vessels, lymph, nerve. Small is in the papillary, the large is in the reticular layer. And the reason why they call it reticular, because it contains reticular connective tissue. Dermatitis, any itis means inflammation. So this is an inflammation of the dermis. Which layer? It's the papillary layer specifically. Papillary layer, it's inflammation, not in the dermis, just like this. It's papillary layer specifically, the superficial one. And anything can cause that. It's not, infection is one thing, radiation, it can be chemicals, poison ivy, and dermatitis. If you ever had inflammation in your skin, it will be painful and itchy. The dermis itself contains two types of fibers, the collagen fiber and elastic fibers. The collagen fibers is the strong one that resists stretching. The elastic fibers is the one that permits stretching and recoil. Okay, so both of them compensate together to make the skin looks like the way we see it. And we hear about advertising about this cream contain collagen, right? This shampoo contain collagen and stuff. This is to strengthen the collagen fibers, and the collagen fibers is what make our skin stretch. And that's why when we get older, our skin starts to wrinkle. And the wrinkling is because of you lose the fat that's under the skin, stretching the skin from one side, and the collagen fibers start to shrink and become weaker. Skin turgors is what make our limbs and everywhere is flexible and resilient. These are the skin turgors, which are like these depressions, turgors. The skin, if it is damaged, like wrinkled or sagged or something, it can be due to natural reason, age. This will happen anyway, as I just mentioned. Collagen, you're losing the collagen fibers, you're losing the fat under your skin. Age, which is affected by hormones as well, hormonal changes. Ultraviolet exposure, I mentioned that we should be reasonably exposed to sun to get the ultraviolet ray, and if you're not exposed to the ultraviolet ray, you are depriving your body from what? Vitamin D. Vitamin D. But overexposure, that will damage your skin. Dehydration, on the other hand, if you ever see somebody dehydrated, his skin will be like when you hold it and leave it, it will go like dough-like. It's dehydrated. It looks like wrinkled. And if this is the dehydration, it's obviously a temporary thing. So when he gets rehydrated, he will be fine. Stretch marks. I think specifically ladies will understand that more. When the ladies are pregnant, this is stretching the skin and stay like that for a couple of months, and then after delivery it goes back and start to stretch back again. But sometimes if it is overstretching, it will leave some marks, and these are called stretch marks. Or if any one of us was overweight or something, or wanted to lose weight, and you stayed like that for some time, for a couple of years, so your skin is accustomed to be stretched like this, and then all of a sudden you lose weight. You are on severe diet for 3-4 months and you're losing 50 pounds or 80 pounds or something. You will lose the weight, your skin will shrink and everything, but it will leave marks. These are called stretch marks, and this occur only if you overstretch it in the first place, not just because you're losing weight. If you were overweight, stretching, or pregnant, and not any pregnancy, it usually happens when the pregnancy, we know that the pregnancy, you can see two ladies, both of them are 8 months, and one of them looks like 3 and the other one looks like 15, right? Yeah, it can happen like this. It depends on a lot of factors, but the point I'm trying to make here is overstretching. Okay, if it is too much, it's both of them are natural. It's probably the weight of the baby and the amniotic fluid around it, and a lot of factors. But anyway, the point is overstretching. When you after pregnancy or you lose weight, you see the stretch marks. Line of cleavage. The line of cleavage is the arrangement of parallel. Of the fibers, elastic and collagen fibers, are parallel to each other, so it will give us this line of cleavage. If you look closer to your hand, it's not smooth. You can see actually lines, very tiny lines, or if you use like a magnifying lens or something, it's not that small, but if you can see it, your hand, I will show you the picture, will have these parallel line, and these are called the line of cleavage. And it is important actually because of two things. Number one, cosmetic surgery. Number two, if you have a wound, how to tell if the wound is going to look okay, it looks nice, like it didn't have a wound in the first place, or it looks different, it looks ugly, it looks like scarred. How is it different? Of course, the cosmetic surgeon, he knows exactly what we're talking about, and he knows how parallel it is, and if he wanted to open, he will open parallel to the line of cleavage. So when it heals, it looks like nothing happened. Okay? You don't even see it. And that's not only here, it's obvious here, but it's everywhere. And this is their specialty. They know exactly where is the line of cleavage, and they can go through it. But on the other hand, if you got an injury or something. Okay? If it is parallel with the line of cleavage, it will heal better, it will look nice, minimal scar. If it is perpendicular, if you cut it transversely, this will give you more scar tissue, and it can leave a permanent replacement of the skin. And these are the line of cleavage. Of course, I'm not going to ask you about this. Just take a look at it. So if he's going to make surgery here, for example, he will open like this. If he open like this, that will leave a scar, a bad scar. Okay, and it's everywhere. If you're going here, you know exactly. Let's open it this way, parallel. So when it heals, it will not leave a mark. If it is an injury, it's an injury. You can't really control it. But if that's the case, you can get suture or something so it doesn't look bad. So in the dermis, we said we have blood supply. Do we have blood supply in the epidermis? It's avascular, right? Avascular. How can the epidermis get the nutrients? From the derms. The derms, the nutrients and oxygen will go to the epidermis to feed it. But there is no blood vessels in the epidermis. So you have these plexuses, cutaneous plexus, venous plexuses, and so on. This is all to supply the blood. But if you have friction or something, you can get contusion. What's a contusion? Contusion is damage of the blood vessels that it looks like black or blue. If you ever have like a friction, hard friction or something, you fell down and you scratched your skin hard enough, you can get bruised. And bruising usually looks like black or blue. This is called contusion. Contusion. Here's another picture showing you all these layers together. The nerve supply of the skin is there to control different things. Number one, the blood flow. The blood flow is controlled by the nervous system. So nerves are there to constrict the blood vessels in your skin. And when you constrict it, if it is cold or hot or warm?
We constrict?
Yeah, when do you constrict the blood vessels of the skin? If it is cold. Why are you doing that?
Keep the heat.
To keep your heat in. If you dilate, the heat will go from inside, from deep parts of your body, which is hot or warm, goes to the skin outside, you lose it. Right? Gland secretion is under the control of the nerves. Sensation, tactile desk. What's a tactile desk? These are the desks that monitor the medical desk, which provide sensation. The next layer is the hypoderms. The most important thing to remember about the hypoderms is two things. Number one, this is the location of the hypodermal injection. If somebody tells you, I'm going to take an injection under the skin, this is where they put it. It goes to the hypoderms. And this contains the fat. So under the skin, it's not one of the layers of the skin. The layers of the skin are epiderms and derms. This is under those two layers. This is where the injection, the subcutaneous injection or the hypodermal, and it's both of them are the same, by the way. Hypo is the same as sub. Dermis is cutaneous. So subcutaneous, hypoderms, both of them are the same. It means same thing. So it contains blood vessels and everything, but the most important thing is fat injections. If the fat's too much, they can actually remove it by lipoplasty. If you ever see something like that, veggies or something, they put like a needle, a big one, under the skin, and they start to suck the fat out, so you can lose some of this fat, which is called lipoplasty.
What's the difference between lipoplasty and a gastric bypass? Or is it like
Yeah, it's completely different. The lipoplasty is you have a lot of fat under the skin, and you physically take it out. You pull it out. The gastric bypass or the lap band, this lap band is a little bit more mild than the gastric bypass. The lap band depends on, you can't eat a lot. So when you eat, your stomach will get full really quick. That's one thing. Another thing is the lab band. The lab band itself will give us the stomach artificial sensation or stimulation where you're full. You're full. Okay? This part of the stomach that they put it at, this is the sensitive part for satiety centers. It sends signal to your hypothalamus, telling your hypothalamus you're full. You're not hungry. Okay? This is one thing. The other thing is it's harder for you when you eat. You feel full. So you eat less. This is a lab band. The gastric bypass is they remove the part of the stomach and making the stomach smaller. You get full easier, and the part that's responsible for hunger, so you don't feel that much hungry. It's a couple of things together. Okay. The accessories. The skin accessories is everything that's related to the skin. Hair, nails, sebaceous glands, sweat glands. And this is all originating from the dermis and protrude out at the derms. We have hair everywhere. The exceptions are, you don't have in your palm, of course, in your sole. The lips does not contain. Portions of the external genitalia does not contain. So external genitalia itself, it does contain, except special parts that does not have any hair. And why do we have the hair? It's an insulator, protection and insulation. And actually it got the openings. So there are openings for the glands that open, like to your scalp and everywhere else. This cover it. So to make it harder for anything to enter through these openings. So protection, insulation, and guarding the openings. The hair itself, the root or the beginning start from the hair follicle, which is deep in the derms. Basically, everything, all accessories originate from the dermis. They will appear in the epidermis, but they originate from dermis. Hair originates or located in the dermis, and the hair is non-living. Of course, if you have a haircut or something, you don't feel anything. It is non-living. And it's wrapped around the sheath, and the base is surrounded by sensory nerves. And that's why if you pull your hair, you feel pain. If you cut it, you don't feel it, because the hair itself is non-living. The deep part surrounded by nerves. So if you pull it, this is when you can feel the pain. There is a muscle that's attached to the hair, which is called erector pili. And erector means erection. And erection means like this. Okay? Like perpendicular, standing up. Like if your hair like this, when it goes cold, it will contract and put it like this, which is called the goosebump. Right? So it's normally the hair is like this if it's cold. So erector pili. Erector means erection. Okay? Pili means hair. So it erects the hair or make the hair perpendicular to the surface. And this is what caused the goosebumps. There are some glands underneath the skin, and the secretions of these glands, sebaceous glands for example, any gland in general, we need to learn this. Any gland, the name usually comes from the type of secretion. So if I say sebaceous gland, why did you call it sebaceous gland? Because it secretes sebum. Ceruminous gland, it secretes cerumen. Sweat glands, it secretes sweat. And so on. Every gland is named after the serous glands because it secretes serous secretions. So this is sebaceous glands, secrete sebum. What's the sebum? The sebum is the oily secretion that goes to the hair, lubricating the hair, and it also contains some antibacterial. Okay? Contain antibacterial. And it is oily material, and we all hear about if you're going to pick a shampoo, specific type of shampoo, there is a regular shampoo, and there is some for oily hair and others for dry hair, right? We have different varieties of the shampoo. Where is it coming from? Sebaceous glands. If you have the sebaceous glands secreting normal amount of sebum, you're fine. You use the normal shampoo. If it is hyposecreted, it's not functioning well. So this oily substance that make your hair soft and lubricated, it will become more dry. So this shampoo is going to, it's not that much, it's more of advertising, but it does have some effect. So it gives you that lubrication effect that's needed. On the other hand, if you're using one of these shampoo for oily hair, it means your sebaceous glands are over secreting. Okay, it's hyperactive for some reason, and it's different from person to person. There is nothing really bad about that, or it's not like a disease or something. It's just different. We're supposed to be like in the middle. Sometimes it's hyper, sometimes hypo. So if it is hyper, the hair will become really oily, and they play with the shampoo to get rid of this oil, extra oil, right? So it's oily secretion. There is a root and there is a shaft of the hair. The root is obviously the lower part and the shaft is the upper part. And here's a picture showing you what I was talking about. This is the root. You see this nerve here? See these nerves? This is the sensitive part. So if you pull the hair, you take it out from this, and you feel pain. If you cut it, this is non-living. It's full of keratin. So it's non-living. So this is the shaft. This is the root. So root is inside, the shaft is this part protruding outside. You see the erector pili muscle I was talking about? It goes like this. This is the hair and attached like this. When it contracts, it goes like this. Okay? So erector pili muscle, and you see the sebaceous glands is not opening to the surface, it's actually opening around the hair. You see that in the picture? So as the hair grow, it will be moisted and it will be oily as it grow. Sebaceous glands. And there's a connective tissue surrounding the hair. This is a cut section of the hair. The inner part is called the medulla, and the outer part is called the sheath. So medulla and cortex and sheath. Medulla, cortex, sheath. There are other layers in between. This is a boundary right here between the root and shaft. So anything under this, starting from here, going all the way until this point here, this is the root. Anything above that is the shaft. So obviously the sebaceous gland open to the shaft. This is a microscopic picture. The hair papilla is what contain the capillaries and the nerve, which is the deepest part. You saw this part? You see this part right here? This is not the root. The root is all of this, the lower half, just this part at the beginning. You see the blue and red? So this is the location of the hair papilla. So this is what contain the capillaries and the nerves. And the hair bulb contains the hair matrix itself, which is a layer of dividing basal cells. So we have in the structure of the hair, you have the medulla, you have the cortex, and the cuticle. Okay, these are there are some details, but this is the most important thing. Innermost medulla, followed by cortex, followed by cuticle. 1, 2, 3. There are other layers, but this is the most important. Now, the hair is full of keratin, so it is keratinized. Soft inside and hard outside. Okay, these are the different layers. The club hair versus the new hair. The club hair is the hair that does not grow. It's attached to inactive follicle. This is the hair that stays as it is, does not get taller or shorter, does not grow. But the new hair, only if the follicle become active and when the club hair is shed or removed. Now we have two types of hair, or the different types of hair. the vellus hair, which is a soft, fine hair that's all over your body. This is a soft part that's covering everything. The terminal hair is different. Like compare the hair of your scalp, the hair, compare it to the eyebrows or eyelashes versus the hair in your abdomen, for example. And you see the difference, right? The hair all over your body, it's soft. This is called the vellus. This and this is the terminal hair, which is pigmented and it's thicker, and it starts to show up in other places after puberty. Example, like the axillary hair, for example. The axillary hair, it's terminal hair, but it only show up as terminal hair after puberty, right? This is one of the signs of puberty, actually. The other hair around the genitalia, this is terminal hair, but it does not show up as terminal hair until puberty. Before that, it's not. The beard, same thing, terminal hair. So any hair is vellus, soft, except those parts that I talked about. The hair color, the color of the hair is mainly by the melanocytes located in the hair papilla, and it is determined by genes. We see this person, his parents, the mom has green eye and the dad has black, for example, and you never know. He might be green, he might be black, he might be something in between, he might be something third. It's all about the genes, where he's getting the genes from. Okay, the glands that we talked about the sebaceous gland, which is secrete the oily substance called the sebum, right? Versus the sweat glands that secrete sweat. Now, there is an important information here to remember. The sebaceous gland is called holocrine. And the sweat gland is called either apocrine or merocrine. Holocrine, holo means whole, means the whole thing, meaning the gland will rupture, secrete the oil, and the gland is gone. Okay? Holo. So the whole gland is not there to secrete, make secretions, continue to secrete. That's not the case. It's actually a whole gland is used producing the oil, and it is gone, and you replace it. Sweat glands is different. The glands will stay there. The cells will stay there. They start to secrete, and stay on. So holocrine or holocrine versus apocrine and merocrine. Apocrine and merocrine are different. Both of them are acrine. So acrine versus holocrine. What's the point here? Holocrine or holocrine versus acrine. Ac means part, external. So this is only secrete. You don't lose it. For the sebaceous, it's holo, the whole thing. You lose the gland itself. Did you get the difference? The acrine, the acrine, which you don't lose the gland itself, you don't lose the cells, but there are two types of them. It can be apocrine and it can be merocrine. So both apocrine and merocrine are acrine or acrine. What do you mean by acrine? You don't lose it. It's just open and secrete. Holocrine, you lose it. It's actually rupture. Okay, so when it secretes the secretions, it's gone. And obviously, the sweat glands secrete sweat, which is watery. And what else does it contain in the sweat? Salt, and sometimes, or most of the time, uric acid or waste products in general, including uric acid. If you don't get rid of it, or if you have extras. So the sebum, one more time, it's lipid, moisten the hair, make it soft, lubricate it, and it's bactericidal as well. Compare types of sebaceous glands. Okay, this type secrete to the hair, which is a normal type. So the hair will be lubricated, the hair will be soft, resistant to bacteria. This one here is more to soften the skin itself, or the scalp, if you're talking about the hair, and protect it from bacterial invasion. Apocrine sweat glands. So, again, we have two types of glands. It's either hollow or eccrine. Holocrine, eccrine. Holocrine, if you lose the whole thing. Eccrine, when it's just secrete. The eccrine is two things: merocrine and apocrine. Merocrine is the regular sweat glands that we all know, that secrete sweat, right? When you sweat, this is a regular secretion. So this is called the merocrine glands. The apocrine glands, these are special types of sweat glands. It's not there to secrete the regular sweating. It's a modified type. And this is basically, it's related to hormones. So it starts to do this action that I'm going to talk about after puberty. Okay, it's located in spots in the armpit, around the nipples, in the groin area, and they secrete secretions. These secretions, when they break down, it will produce this odor. They say it's sexual attraction. This odor. So this is a special function that start to do that only after puberty. Okay, a specified or a special type of sweat glands that the secretions are affected by hormones and nervous system. When it breaks down, it will give this odor for sexual attraction. So this is obviously in certain location related to the function. Okay, it's not the regular sweat. That if it is hot or warm, we get the regular sweat. This is more related to the hormones and the sexual cycle. So this is the apocrine sweat glands. This is how it looks like. And it will secrete, and the secretions will break down, giving you that odor. Merocrine glands, this is the regular sweat glands. It's everywhere. And does it produce sensible or insensible perspiration? Sensible. Is that right? What's the insensible?
The sweat. You sweat when it's hot.
This is sensible. Still. Insensible is what evaporates from the interstitial fluid. It's not sweating. Sweating is you're actively producing fluid. Okay, the fluid goes out from the ducts and it is released on the skin. This is different. This is just evaporation of the interstitial fluid. When I say you feel it versus you don't feel it, I'm trying to make it closer to your mind so you remember it. But the actual thing is, this is the actual sweat. The gland make it, duct take it out. So this is the sensible. The insensible is the evaporation that's happening all the time from the interstitial fluid. And obviously all types of sweat contain antibacterial components. Other types of integumentary glands. So we talked about the sweat glands, sebaceous glands. There are two types of sweat glands that we talked about. And now the mammary glands is another gland that's related to the skin too. So it's considered integumentary. And obviously this is to produce milk. Ceruminous glands, again the name come from the secretion. So ceruminous, because it secretes cerumen. Sebaceous secrete sebum. Serous secrete serous fluid. Okay? Sweat secrete sweat. So the name always comes from the name of the secretion. Ceruminous gland produce cerumen. What's the cerumen? It's for airwax, producing the airwax. Okay, the airwax is actually there for a reason. It's for protection. The most important and the most sensitive part is the eardrums, tympanic membrane inside. It's extremely delicate. If anything go to it, it can rupture it. It can break it down. So you have these cerumen. If anything goes, like dust or anything that go, insects sometimes can go in and if it reaches the eardrum, it's a problem. And so this is to trap anything trying to get in to protect you. So it's there for a reason. So we don't remove it actually unless it's over secretion. So as long as it's not bugging us, it's not bothering us, it's not blocking the hearing, for example, we shouldn't remove we remove the extras only, but it's there for a reason. I remember about the cerumen. I remember one time I was at the ER, or the reception at that time, and I saw a kid coming screaming, and like this, my ear, and we started to look inside. There was actually something like a mosquito or a small fly that got in, and the legs got stuck on the wax, and every time it tried to fly, it's very close to the eardrums. Every time it tried to fly, it started to vibrate very close to the eardrums, and he started like screaming like crazy. It's very painful, of course. If something like that happened like here, that would be painful. If you take it all the way right beside your eardrums, it's horrible. And all what I did is, there was an oil there in the reception in the hospital. I put some couple of drops, so that actually killed the. I don't remember exactly, was it a mosquito or a small fly or something like this. So we just put a couple of drops of oil, warm oil, so it sink it all together, and we just make an air wash, get rid of it. But I still remember that, but it was crazy. Like, he goes screaming, and then he calmed down. Obviously, when the mosquitoes calm down, he's okay. When it start to fly again, horrible screaming, and I imagine how bad it was. But again, 2 drops of oil, just and this is the cerumen or the air wax that's protecting our eardrum. The glands are controlled by autonomic nervous system. However, the merocrine glands are controlled separately. Okay, so it's usually independent. If the weather is hot, it's going to secrete. If it is cold, it's not going to secrete. While the sebaceous glands and apocrine is controlled more through the autonomic nervous system. Like I talked about the apocrine, and it is related to the sexual cycle. So if during sexual excitation or something, the parasympathetic nervous system will stimulate these glands to secrete the secretion for that purpose. Excuse me. Thank you. Anybody didn't get sick yet? You all get the cold? Obviously, it's a horrible strain. I know like half of the people that I know get cold. Okay, thermoregulation. Regulation that we talked about before, which is regulating the body temperature. Again, if it is hot, if it is warm, dilate the blood vessel in the skin, so the warm blood inside of your body go to the skin, you get rid of the energy in the form of heat, and the other way around. Next thing is the nails, and the nails are obviously to protect our fingers, and it consists of dead packed keratin. Okay, so what was the hair again? Dead keratin. What's the most superficial layer of the skin? Dead keratin. What's the nail? Dead keratin, right? So it's all keratin. Dead keratin, it's connective tissue, dead. And also, the metabolic disorders can show up in the nails. So example, if you look at your nail and it looks normal, that's fine. Sometimes you see it white or patches that are white. It means there is a metabolic disorder going out there. And sometimes actually you see something called clubbing of fingers. Clubbing of fingers, I saw that in the clinic. You know how the spoon looks? The spoon looks like? It looks like spooning of the finger, looks like a spoon. Instead of being convex like this, it's concave. And this is, if that's the case, it might mean something in the liver. Something bad in the liver that reflects on the nails. So the point here is the nail can reflect something. So when you go to the doctor and he's doing the general examination, nothing is done randomly. When he look at your nail, he's looking for a reason. Okay? It might be white, it might be brown. If it is white, it means something. If it's brown, it means something. If it starts to spoon or become flat, this is related to the liver function that can show up here, and so on. So it actually does mean something. And the root is what comes close to the bone, and then you have the body, the linula, and the sides. Let me show you the picture. Here is a picture to make more sense. So here, this is called the proximal nail fold. Okay, this is the nail fold itself, and you can look at your own finger and see it. And then the edge of this proximal nail fold is called the eponychium. Did you ever see like the skin is growing with the nail and you start to push it back, right? This is the eponychium. So the eponychium is part that's actually adherent to the nail. When your nails start to grow, sometimes most of the time it's just your nail grow without it, but sometimes it grow with the nail and you have to cut it or push it back or something. This is called the eponychium. The linula is this white part at the base. You can see it in your own finger right here. This is called the linula, and it's called the linula because it's lunar shaped. Okay, this is the nail itself. This is the lateral fold right here. So we have proximal fold, which is more proximal, and you have two lateral folds. This is the free edge, this part right here. Okay, and here's again the proximal nail fold, which is this part right here. This is the root, linula again, the body, and this is called the hyponychium. And the hyponychium is the part that we always clean, right? When you clean your under your fingers, this can hide bacteria and any other organisms. Okay, so these are the different parts of the nail, and sometimes the nail can grow. See, this is the lateral nail fold. Sometimes it grows lateral. What do you call this condition? If it grows lateral? Ingrowing nail. Ingrowing nail. An ingrowing nail is the nail naturally try to grow everywhere, not necessarily anteriorly or distally. It tries to grow distally and to the side as well. But if your lateral folds are strong enough, try to grow and the folds stop it. So that's why it will find one way to grow, which is the natural. Sometimes if the nail folds are weak, a little bit weaker, or there is something wrong with it, it can grow laterally, and this is the ingrowing nail. And this is more if you're wearing like tight shoes or something, it can push it more to the nail, can start to harm this part of the fold and can grow. And actually I myself got the ingrowing nail one time, and I did a surgery for myself. My wife was thinking that I'm crazy. I didn't use anesthesia or anything. I just got the tools, start to take it like this, make it like, yeah, scalpel, okay, and I cut like the outer 20%, the outer part that's more to the lateral fold, and I then snatch it, and my wife was screaming, "You're crazy!" No anesthesia, nothing. I said, not me. And it was not that painful because when it grows in, okay, this part become less sensitive. So I just got the scalpel, cut it, and take it off. Actually, when I was working in the hospital, like in Egypt, when I see patients we see patients like this all the time, having ingrowing nail. So I actually give them the choice: do you want to take anesthesia, local anesthesia, or not? Of course, yes. Okay, but I'm going to give you like 3-4 injections. It goes like this: one here, and one here, and one here. Or can you give me 2 minutes? I just take it. Okay, take it. Usually men tend to do so. Just do it. So get it done. If I wanted, if not, okay, I'll give you anesthesia. Right? We'll put one here and one here and one. So I'm hooking you anyway, 3 times. It's painful anyway. There is no way. It doesn't go like the local spray. It doesn't do much. This is just superficial. Deeper in, you still feel it. So yeah, I always used to give the option to the patients. Do you want to get 3 injections, or just give me 2 minutes or 5 minutes and I will get rid of it? Women, no. Girls, no. You have to give me injection, 3 injections, okay? Men, just do it. Okay, this is for the nail. Repair of integument. We usually, if something happened to the skin or something, we start to bleed first. After you bleed, you start to get the inflammation. And then you get the scape, which is protecting the area, and germinative cells start to migrate to repair the area. Then the macrophages start to clean up. Cleaning up what? Cleaning up eating everything. Not only the bacteria, the dead cells, the remnants, anything that's not supposed to be there. Like if you have a wall that was broken for some reason, right? You put something temporarily to seal it first until you start to fix it, right? And when you want it to fix, you clean up first so you can build on clean base. And this is what the macrophage does. There are remnants and there are dead cells and bacteria and other things. They eat everything, clean it up, even your own cells. If it is dead, eat it, remove it, so you can rebuild on a clean skin. At the end, the fibroblast and the endothelial cells will move in to make their granulation tissue. And the scape is actually, if you, at any time if you got a wound or something, start to bleed and then stop, and you see something like a red, if you rub it or even if you touch it, it's going to bleed again, right? This is the scape, because it's something temporary. It's not a fix. It will be lost anyway. It will be removed. Don't remove it. Underneath, the germinative cells are going to make a layer underneath. The fibroblasts will make granulation tissue underneath, and it will heal, and this will fall by itself. So this is just a temporary seal. And I call it escape. Is like if you got a broken pipe or something in your house. What's the first thing that comes to your mind? Put something on it so it doesn't leak all over the house, right? So this is something temporary. This is a temporary seal. It's platelets, seal it first, and then the escape, like you wrap it or put something around it until you call like the plumber to come over and do a permanent fix. So this is something temporary until the germinative cells come, start to heal, start to remake the cells that you lost. Macrophage clean, fibroblast put some granulation tissue. So it goes like this. You start to bleed first. This is the granulation tissue. Macrophage and fibroblast will come. This is the escape that will be removed anyway. And the cell will start to build underneath. Macrophage clean. Fibroblast put fibers. So we make granulation tissue. Here is the cell. Where is this coming from? Look at this. Where is it coming from? The purple that's under the escape. Where is it coming from? No, these are cells. It's similar to this. From which layer of the skin? Germinativum. It's coming from germinativum. So the germinativum will start to make under the scape like this, and underneath here the fibroblast will start to form, which is granulation tissue, until this is completely repaired. You don't see scape anymore here. So this is the whole process. Are we supposed to finish at 9:30?
Yeah.
Right, okay. So the fibroblast is what's going to produce the scar tissue. After that, the inflammation starts to decrease. The clot will disintegrate, meaning it's going to fall down. Get rid of it. It will become stronger. But the problem is sometimes you get a keloid. You see a keloid before? This is an overgrowth of the granulation tissue. You're supposed to have granulation tissue enough at the surface of the skin, not above the surface, not protruding out. It should be right at the skin level, and it shouldn't be much like this. If it is like this, it's an overgrowth of the granulation tissue, and it is actually affected by genes. It has some genetic factor. It's why we don't all get the same thing. Okay? We can, me and you and somebody else, we can get the same type of wound, exactly the same process, same everything. You get a keloid, I don't get it. It has some genetic basis. Now burn. When somebody got a burn, we need to classify. There are two different ways to evaluate the treatment. We are doing one of them, which is the area. The other one is how much of the skin. Did you get part of the epidermis? That will be stage 1, or first degree burn. If you got the whole epidermis and you start to get to the derms, that will be second. If you get the derms and underneath, that will be the third degree. So obviously the first degree is the mildest, but we will take it more from the area point of view. And I call this the rule of 9. And to remember it, 9, 9, 9. Put 2 9s to make the lower limb. 18, 18. Put 2 lower limbs together. 18 and 18 is what?
36.
36. Okay? So 9, 9, 9. 2 9s make 18. Another 2 9s make 18. 2 18s make 36. And the genitalia is 1%. The remaining 1%. Do you get this? Right? So if I ask you, you can count, right? 9, 9, 9, 18, 18, 36, and the remaining is 1%. The kids are a little bit different. The head of the kid is larger. It's not really larger, relatively, in relation to the skin. It's not 9% of the body. It is 15%. How much is the difference? The difference? 6%. Where did you get the 6% from? You get 4% from the trunk and 1% from each lower limb. Can you remember it this way? One more time. It's 9s. 9, 9, 9, 18, 18, 36, and 1%. This is for adults. For children, this is not 9. This is 15. Where did you get the 6 from? I took from here 4 and 1 from each lower limb. That's it. Can you remember it this way? This is how the calculation are done for the percentage. And this is just for your information. It's used for rehydration and the medications and other things. So if it is more area, you rehydrate more and so on. Aging, effect of aging, it's always the same, always. Everything deteriorates with age. Epidermis, thinner, weaker. Dendritic cells, less. Vitamin D3, less. Melanocyte, less. Glandular tissue, less. Everything goes down, and if you wanted to answer any question, unfortunately, just use the bad ones. Weak or strong? Weak. Number? Down, small. Immunity? Less. Okay, glandular tissue? Less. Activity? Less. So this is how it goes. Vitamin D3? Less. And so on. What are the Langerhans cells? Or dendritic cells? What are these? Remember I told you that the cells of the Intgumentry system are important? All the cells, I told you about that. Langerhans, dendritic cells. These are the immune cells. These are the immune cells of the skin. So blood supply, less. Hair follicle, less. gets active, so the hair start to fall down, and this is where you see older people start to get the hair falling. And it is genetics play an important role. Sometimes you see it's and it's of course it's more in men. Sometimes you see a 30 years old man start to get balded, and sometimes you see 50, 60 years old man who's not balded, right? It will become weaker anyway, but the genetics will play an important role. Elasticity will become less, and this is where you see the wrinkling of the skin, hormones, the repair. You get a wound, and it heals in 3-4 days. He gets a wound, and he heals in 10 days. So the healing process is actually slower. Okay, this is just summarizing what we talked about.